Hello, welcome to my virtual talk today. I'm going to be talking a little bit different subject than I think the meeting has focused on so far. But I think it's something that a lot of people find very interested in, that we now can create human-on-a-chip-based systems as alternatives to animals in the use of drug discovery and it's for efficacy and toxicity. And I'm going to try to address that today. And so my description is I'm going to talk about the human-on-a-chip-based systems. You can read through it yourself. You don't need me to read it to you. But the main learning objective is to try to understand how human-on-a-chip systems work. I mean, what am I really talking about? And we're applying these also to overdose models for opioids. I've changed a little bit of the focus of the talk since the abstract went in, but we certainly will cover that as well. And really to understand human-on-chip systems in terms of regulatory science and activity, and also therapeutic and index determination. So, how you can use these systems to work directly with medicinal chemists to give information on efficacy and off-target tox for both parent and metabolite using milligrams or less of a compound. So it kind of changes how you would do your initial tool evaluation before you would have to scale up. So again, this you can read through this. You don't need me to walk you through it all. And then I will talk about Hesperos is a company founded by Mike Schuller and I. Mike is considered the founder of the body on a chip field. We've licensed about 20 patents from University of Central Florida, where I'm a professor, as well as from Cornell University, where Mike Schuller is a professor. We won the Lush Prize in 2015. We have won multiple NIH grants to try to more automation, higher throughput for these systems. Just moved into a new 14,000 square foot facility last year. About 27 people in the company right now, and we're a service-only company or a CRO. So I really want to focus on this whole idea of clinically relevant functional readouts. So, well, what does that mean? When you walk into a doctor's office, he doesn't immediately, stick you in your arm and be able to pull out blood to be able to look for biomarkers. He looks, how are you walking? Are you talking okay? Are you making sense when you're talking? He checks your reflexes. He listens to your heart. These are all what we call functional readouts, okay? And things like muscle contraction, electroactivity of neurons and cardiac cells, neuromuscular junction formation, barrier integrity, and we've got lots of barrier tissues in our body, everything from blood-brain barrier, the GI tract, to kidney, to vascular systems. These are what we call functional readouts, because we can use MEMS devices to integrate with the biology to then non-invasively monitor these, functional aspects that are very clinically relevant, because these are the kind of things that a physician would like to monitor in a patient during a clinical trial or just simply during a visit. And again, it involves understanding how a drug is interacting with these systems without cell death as being the primary endpoint. It allows us also, in some degree, to start looking at mechanisms. So what we try to do is build phenotypic models in many cases, and then if we can actually then find a target in terms of toxicity or efficacy, these systems can be used to potentially do that as well. So you're very familiar with this idea of a PK model, a physiologically based pharmacokinetic model. You use this kind of model to try to be able to predict what would be a good concentration to go into a phase 1 clinical trial. So Mike Schuller about 25 years ago said, look, I can take these equations, redo them, and be able to design a chip-based system. This is one of our more advanced systems at this point. This is for our overdose model. Again, where we have liver, cardiac for both electrical and force generation, a kidney module to be able to look at barrier integrity in terms of the tox target, skeletal muscle, and then actually the component of the pain would be either nociceptor or for PreBotc neurons, which are controlling the rhythmic breathing, which is the main part of your brain that's affected during an opioid overdose. It basically stops you from breathing. And we'll talk at the end how we can actually build those systems. One of the more important things to mention is that you probably, if you've seen these body on a chip or human on a chip or lab on a chip based systems, you have these tiny little bits of plastic or MEMS devices or chips that then have all these tubings and all these pumps connected to it and all this different hardware. So we avoid a lot. That has lots of inherent problems with it. So we avoid that by actually using a rocker platform to pump things by running it back and forth. And so we can vary the tilt angle and also the speed to be able to vary the flow rates as well as the shear stress in the system. This made it on the cover of Lab on a Chip in 2010. And not only does it get rid of all the bubbles, the tubes and the pumps, but it also makes it a low volume system. So if we have a liver in the system, we should be able to see not only parent, but also metabolite's effect in the same system. It's a very busy slide, but I'm just going to go through this. This was first published in Biomaterials in 2015, which is basically deconstruct the heart into its principal components, which is electrical activity and force. And so what I can do is I can actually pattern cardiomyocytes over top of microelectrodes on a microelectrode array. This is what one of those chips look like. And from that I can get rhythm generation, conduction velocity, AP length or QT interval. Now based upon this cantilever system, I can then take this thin piece of silicon, grow cardiomyocytes on it, and then I can, as the cardiomyocytes contract under an electrical field or spontaneously, I can bounce a laser off the bottom of it. So when it contracts, okay, I can measure that deflection. Since I know the force constant of this piece of silicon, I have the spring constant, I can then measure the force. So this is kind of what happens is if you have a non-pattern system, you see a disorganized filaments in the system. So if you had like a electrical activity starting here, would you see dispersion losses and it would gradually go away as you went further away. Whereas on the cantilevers or on the patterns, you see that these tubules then line up. So whether it be a short path length or a long path length, I get the same conduction velocity in the system, which allows us for spontaneous activity to measure over each electrode as it's moving away from the source of the signal, or better yet, stimulate it, say at this electrode, and then follow the action potential as it goes over each electrode. And the nice thing, I can also measure QT interval at every point along that way. And in this particular experiment, the conduction velocity was 0.42 meters per second. In the human adult heart, it's about 0.5. And we use mature cardiomyocytes in the system. In our system, we can get it to be about, after 14 days, to have minus 85 or greater resting membrane potential and also T-tubule formation. And then so we can then take this system and be able to look at cardiac toxicity. And we can actually then, we've done over 50 drugs with this system. I'm going to focus on 3. Norepinephrine causes the heart to speed up, which is exactly what we see. We can do a dose response curve with that. Verapamil causes the calcium channel blocker, which basically causes the force to go down. And sotalol is very interesting because it can cause a QT elongation, okay, which is why it was pulled from the market. But it doesn't have any effect on the force. And so if I had a unknown toxicity and we had our phenotypic model and we saw this, we'd be able to say, okay, we can focus on the pathways that involve electrical activity and ignore the ones that have to do with force. So we can only start looking at mechanistic determination for targets as well. And again, the same rationale occurs in efficacy. We've also been able to take liver cells in both 2D and 3D environments and grow them out to 28 days in our system. And again, all the culture systems I'm going to show you today are all serum-free media. I banned the use of serum in my lab about 20 years ago. So everything I'm going to show you is all human and serum-free. You can also look at the CYP activity is maintained for, in this case, 1A1. Okay, in the case 304, basal activity and also induced activity remains very high and stable for 28 days. And this was just published in Biotechnology Progress. Now what we can do is we can actually then combine those chips for the cardiac, electrical, and force with this liver-based system, and then use it to then monitor the force, the electrical activity, and then in case we can actually then look at biomarkers as well for the albumin and urea production, and then look at CYP activity as an endpoint analysis. This is what that system looks like after it's been assembled. This work was done with AstraZeneca. It was published in Nature Scientific Reports. And what they wanted to do was to look at a proprietary compound. They didn't understand the toxicity, but they first wanted us to actually validate it using a very well-known couple, terfenadine, fexofenadine. Terfenadine is a well-known cardiac toxicant. It causes QT elongation, whereas its metabolite, fexofenadine, is not. And so again, this is no pumps or anything. This is the entire volume of the system, about 2 mils. And so we do a cardiac-only system. You see here that there's a fair amount of toxicity for QT interval, but as soon as we add a liver to the system, it shifts to the right. Conduction velocity, almost no toxicity with the liver present, and a fair amount of toxicity, IC50 of 33 micromolar, when we're looking at the cardiac-only system. But again, getting back to this whole point of functional readouts without toxicity, the cardiac viability was not affected. Now, the other main point I think you'll find interesting is we can create PBPK models of our in vitro systems. And so we can then model the mixing, the flow rates. We can then monitor that over a period of time. We can look at the mixing. We can also look at loss. These compounds will absorb to some of the materials. Terfenadine absorbs a lot, fexofenadine not very much, but we can actually build that into the system. So we can actually then have the mixing and the loss to be able to actually look at the area under the curve for the exposure to start calculating the PD or the pharmacodynamics in the system as well. So you can create these algorithms where we account for absorption losses of the compound. We can account for metabolism of the compound, be able to then monitor the medium concentration, understand what the pharmacodynamics is in terms of exposure with the cardiac cells, and then how much gets across the cell membrane, in this case to affect the field potential duration of the hERG channel, which is one of the main drivers for cardiotoxicity in terms of QT elongation. You can see again, we can calculate the PK and then be able to get the pharmacodynamics out of the system. Now, in this paper, we use that in vitro PKPD relationship to be able to then compare it to in vivo data that AstraZeneca had for guinea pig, dog, and non-human primate, and show there was a very good correlation. So another key point to take away from this is that we can use these in vitro models, create in silico PKPDs, and be able to use that to start predicting outcomes in terms of what will be happening in a in vivo or potentially a clinical environment. Now, we did another project in collaboration with Roche Pharmaceuticals. And I mentioned the previous paper was published in Nature Scientific Reports. And they said, well, okay, that's a very nice set of data you have there for toxicity, but can we combine, say, cancer as a efficacy target with your cardiac and monitor both efficacy and off-target tox in the same system? This is one of the real main points of the presentation. And they said, well, okay, let's make it really difficult. Let's do a multi-drug resistant cancer and a non-multi-drug resistant cancer in your system. They chose as the chemotherapeutic tamoxifen. Tamoxifen by itself is not a very good chemotherapeutic. However, its metabolite is. So when we added the liver to the system, we saw efficacy in terms of decreased proliferation for the cancer cells. We added its metabolite. It's about the same as with the liver there. Then we looked at the multi-drug resistant cancer, and tamoxifen with liver, its metabolite didn't do anything, but we added a second drug, verapamil, which is known to block the channel that enables this multi-drug resistant behavior for the cancer cells. It blocks the channel that actually pumps out the chemotherapeutic normally as fast as it comes in. We see a decrease in proliferation of those cancer cells, and we don't see any increased proliferation decrease in the non-multi-drug resistant cancer, showing that verapamil is not actually causing the decrease by itself. It actually is blocking the channel. Now, if we then look at the off-target toxicity, you can clearly see that for the conduction velocity, it goes down with tamoxifen but recovers. Force goes down but recovers. Beat frequency goes down but recovers. But in the drug-drug combination, which is a a rapidly increasing method of treating cancer patients, which is drug-drug combinations, we see that the drug-drug combination for the off-target toxicity, conduction velocity comes down, but does not recover in 3 days. Okay, force goes down and starts to recover, beat frequency goes down and recovers. But again, cardiac viability is not affected in this case. And so what this would tell you is that, well, you've either got to wait longer than 3 days with this drug-drug combination before you can administer it again, or you've got to replace verapamil with something that is not as toxic when combined with tamoxifen. And it just clearly shows that the liver off-target tox was not affected, even though the liver maintained metabolically competent during the entire experiment. And this was published in Science Translational Medicine last year. Now, we can also look at neuronal-based systems. We can look at the neuromuscular junction. We can actually take human motor neurons from induced pluripotent stem cells and take also human muscle from either primary or induced pluripotent stem cells, grow axons through these microtunnels here to innervate them to form NMJs, and use this as an assay as well. This is kind of a picture of what it looks like here, where you can clearly see the motor neurons on top of the microelectrodes, you can see myotubes on top of the cantilevers, or we can do motion capture in here of myotubes that are innervated through the tunnels. You see the axons going through the tunnels, very nice neuromuscular junctions in the system. We published the first dose response curve with a human-based system for Botox back in 2018, where our IC50 was close to what the prescription claimed what the correct dosage would be. We can also apply this system to look at disease models for efficacy. In this case, we looked at ALS. We were able to differentiate out the mutations for SOD1, TDP43, C9, and FUS. And again, we can actually take these induced pluripotent stem cells from disease models, put it in the system, be able to do motion capture, compare the wild type, show that the ALS mutations cause skipping in the system. So we actually have a phenotypic model. So if we can then, in this case, we had a compound that actually restored the skipping, we can actually have a comparison here that the FDA is something that they would consider for showing efficacy in one of these systems in terms of a phenotypic model. How did we arrive at that? Well, we talked to somebody who was actually running a clinical trial for ALS and said, well, what are some of the things you have people do during a clinical trial to evaluate whether they're getting better or worse? So one of the simple things we do is have them take a task and do it faster and faster, like just simply moving something across the table. And and they find is that as they do this faster and faster, their hands start to get tremors, little spasticity, they start losing grip strength. Well, we can measure that. We can increase the stimulation rate of the motor neurons and actually eventually drive it into tetanus. So looking to see whether or not we're getting a contraction every time we're doing a stimulation, and also whether or not tetanus is maintained in the system. It's a very busy slide. This is a paper which was published in Advanced Therapeutics. You can see here we got the wild type system. So we can actually then stimulate the motor neurons and measure what the muscle is doing, or we can measure the muscle directly to prove that any effects we're seeing is through the neuromuscular junction. You see here the SOD1 motor neurons actually causing skipping and variety of systems, actually, but the muscle is fine. Another mutation for SOD1, it also has deficits in the stimulation behavior, but the muscle is fine. And then the FUS also has deficits in skipping in the system as well. If we then also can look at the fatigue index in that system, basically, well, how long do they maintain tetanus? You see clearly for the mutations that the fatigue index goes up, okay, with time and culture at 1 Hertz and at 2 Hertz. So what we wanted to do is see whether or not we could rescue the fidelity using a protocol, DAMGO protocol, which was developed a holistic treatment that has been used by many, many ALS patients, was come up with a doctor to try and treat his own daughter, that has shown, again, some anecdotal evidence of helping patients maintain their function for longer periods of time. And we clearly see when we actually then treat these systems, okay, with the DAMGO protocol, we get at the higher stimulation rates, we get maintenance of fidelity, okay, with these systems after treatment. and actually then see this for day 17 as well. You see some increases in terms of rescue of fidelity, and also rescue of fatigue in the systems. You see that also for the 1 Hertz and 2 Hertz, day 14 and 17 for these systems, to the point where at day 17 we see almost complete rescue, okay, of the deficits caused by the mutations in the motor neurons from the ALS syndrome. And again, this was published in Advanced Therapeutics. And again, the citation is listed on the slide if you want to have that. We've also been able to differentiate from induced pluripotent stem cells the muscle now, and shown that the muscle fusion index and force, okay, in Myotube area was compromised for the mutations for the muscle as well. And this was just published in Nature Scientific Reports this past month. So we can actually then start doing all the different components of ALS and building phenotypic models by taking the induced pluripotent stem cells from the patients. And we can apply this not just to ALS, but pretty much any rare disease or any rare disease where we can get a hold of patient samples, identify what are the main tissues that have deficits in them for the disease, differentiate those tissues, and show we have a deficit compared to the wild type. We're also very interested in CNS models. In this particular case, I'm going to focus on Alzheimer's. So we're very interested in using a hippocampal layer to inform a cortical neuron layer. I'm just going to give some data on the cortical layer at this point. What we want to focus on is the fundamental unit of learning and memory, something called long-term potentiation. The first thing we want to do is try to be able to take neurons and hook them up, and we use surface chemistry, okay, on these chips to be able to guide where the neurons are going. You can clearly see that this is a neurons here putting out a process, exploring its area, the area where we actually have the somal adhesion sites. There's information back and forth. It then tells the cell body it can translocate. Then it cuts out the neurites to become axons and dendrites in the system. We can then build that on top of microelectrodes. Here, you see the axons going back. Now, this is a collection of neurons. It's not single neurons, but the same principle to be able to hook them back up. We're just, plating them down and then actually spontaneously forming these axonal tracks using the surface chemistry as cues. So what we can do is we can actually then stimulate them to cause long-term potentiation in the system. And what we wanted to do was to look at the effect of A-beta oligomers and tau oligomers on the system. So we did an A-beta scrambled. We didn't see an effect, but the A-beta non-scrambled oligomers abolished long-term potentiation. And the tau, same thing with the control. We didn't see an effect, but the tau oligomers abolished the long-term potentiation. And this was published recently in Alzheimer's and Dementia this past year, detailing this as a system to be able to analyze what drugs would do in trying to reversing these deficits. Now you say, well, okay, you're using single cells in here. How would you do multiple neuronal cell types or different cell types in these systems? Well, Tom Bolin and I invented bioprinting back in the early 2000s. These are some of the early papers on that. So we can use this idea of bioprinting and say if we're interested in Parkinson's, we could print dopaminergic neurons here and cortical neurons here, and again have the same patterns going back and forth to be able to look at other disease models as well. So what we can do, we can actually then combine all 4 of those organs I've then presented to you into one 4-organ system with cardiac, skeletal muscle, neuronal, and liver. We can then model it to be able to look at the shear stresses and flow rates. And these were published, the first one in Nature Scientific Reports in 2016. And in 2019, we published Advanced Functional Materials, this out to 28 days. 28 days is a very important period for most toxicologists, was well known. That's the time period generally where you do an animal experiment for looking at systemic toxicity. So we're able to show with the system that the liver in a 4-organ system was able to be competent out for 4 weeks. You see in a static system, primary liver lost its capability to produce albumin very quickly. However, in the 4-organ system is very stable. Urea is also very stable, and CYP activity was maintained for 28 days in the multi-organ system. Cardiac on the cantilever is maintained for 28 days, and to be able to look at force. Conduction velocity, you see the patterns maintaining for 28 days in the recirculating serum-free media system. This is kind of what it looks like here assembled. And again, it's a serum-free medium recirculating for 28 days, bathing each organ, okay, in the medium. Muscle, you can see the cantilevers after 28 days, very nice stable behavior. And then motor neurons also patterned over microelectrodes. Okay, and again, very nice spontaneous spike amplitude, and spontaneous activity goes up with time because they have further maturation of the neurons in the system. I also want to now say how we've then adapted this. I showed you in one of the first slides the opioid overdose model we're creating. And again, this is what it looks like here. So what we're trying to do is to evaluate acute and chronic effects of overdose and overdose treatments for naloxone. I mean, what happens if somebody who is addicted is not just treated with naloxone once, but treated 20 times? Okay, they're starting to find some toxicity is affected with that. And so at the same time, we're monitoring the ability of the neurons to go into overdose and be recovered. We're also looking at the off-target effects, both for the opioids and also for the naloxone treatments in the system. And then we're also then going to, in the second phase of the project, look and see what happens when we add an immune system and also with disease comorbidities. It's a very busy slide. You can go back and, pause it if you want to look at the data, but it's basically all the different markers to show that we actually have the PreBotc neurons. And these are the final two markers that are most important, the NK1R receptor and the mu opioid receptor, showing that we get both of them in the system to show that we have the immunocytochemistry to show that we have the markers. And electrophysiologically, we have patch clamp. ATP stimulates the PreBotc neurons as well as substance P. We treat it and you basically get them to turn back on. And then SST, somatostatin, basically turns it off. And we basically have the stimulation and then the cessation of activity in the system. And then we then treat it with a opioid DAMGO and show that we get a decrease in, as we increase the concentration, a decrease in firing activity, which we can then monitor and develop a IC50 of 9 micromolar, which is in pretty good agreement with the literature for these systems. So we actually have now an overdose model, which we've been able to show that naloxone will rescue this. We can actually then reverse these effects, and we're now doing the experiments with the multi-organ system to be able to look at the efficacy and off-target tox or therapeutic index for these systems in the same system. Now we're also, as I mentioned, we have a immune-based system. This was just published in Advanced Science this past year. You see these are that multi-organ system. You see the monocytes of these white dots here flowing back and forward over top of the microelectrodes. Okay, and we can actually get the monocytes in the system to not be activated by flow. And you can see here that the CD14 positive cells are the unactivated, whereas the CD69 is activated. You see both activations. You would actually have an inflammatory macrophage. You see very, very little of that, just by simply being in the systems. However, we can treat them with IL-4 and activate them and show that we get very good activation of the immune cells in the system. Now we wanted to look and see whether or not we can recreate the innate immune system. So could we actually go in and selectively damage one organ and see the immune cells only going to that organ with a characteristic of a M2 or restorative macrophage, and then treat a bacterial protein in it and get the immune system ramped up so we're having an inflammatory macrophage and see it damage all the organs. So we treat it with amiodarone. Amiodarone is affecting cardiac cells, but it does not affect the skeletal muscle or the liver. We clearly see the infiltration of the fluorescently labeled monocytes into the system. And you clearly see, as well as the presence of amiodarone plus the immune cells, here you get your highest toxicity. It gets maintained for both the cardiac force, conduction velocity, normalized beat frequency, but the muscle is not affected in the system. We also see, when we look at the cytokines, that pretty much there's only one cytokine that is substantially elevated, which is IL-6. Okay, IL-6 is the signature for the M2 or the restorative macrophage. We can then treat it with bacterial protein. In the preliminary experiments, we showed that we get activation, CD4, and then also IL-8 production in the system. We then treat the entire system, show basically that the effect of the monocytes with the bacterial protein and the IFN protein as well causes a decrease in skeletal force, decrease in muscle, as well as force here, and also a decrease in albumin production. So all the different organs were affected, and you see that the IL-8 is sustained high, IL-10, RANTase, MIP-1, and TNF-alpha, okay, which is what you'd expect with a inflammatory macrophage phenotype. And also you get the CD11B immunocytochemistry in the system with post-drug, showing at the end these are getting activated into an inflammatory phenotype for the immune-based system. So lastly, I don't have time to get into this in detail, but we can actually add barrier tissues into the system as well. In this particular case, we worked for many years with L'Oreal, and so we can actually add in skin into the system. So you can actually have a 5-organ system with skin. I've already shown you that we can actually add in the kidney cell into a multi-organ system. We can use that as a tox target. This is actually out of a paper from Mike's lab at Cornell, but we have this in the company as well, to be able to create a blood-brain barrier-based system. And you can see that here in terms of the TEER values being around 3,000, a GI tract system where your TEER value is about 300, which is what you'd expect. Again, nice barrier function in both systems. And also transporters, you see that compared to the on-chip versus the in vivo, this should be about a 45-degree line for these compounds. This is approximately what we see. So what does this mean in terms of regulatory aspects? It can actually allow preclinical results to steer limit clinical trial construction. In fact, come up with your companion diagnostics at the preclinical stage. Reduce the number of people necessary for a phase 3 clinical trial by trying to create all the human variants for uncommon genome profiles. You know, like Vioxx was a 30,000 person clinical trial, but still failed after going into circulation and prescription. And again, well, you know, when we even for 30,000 person clinical trials, still things were missed, and hopefully we can identify all the different genome profiles and be able to do clinical trials primarily by using the system with limited number of humans in the system. I've already showed you examples for rare diseases, better evaluations for children, aged individual, and again for the cancer, something we're already doing right now, which is doing precision medicine with individualized cancers in these systems. So I'd like to thank NIH for funding, lots of corporate partners, and then without the people, we would be nothing. And so this is the people from my lab at UCF and also at Hesperos. I'd like to thank them. Thank you for your attention. And this will be virtual, so I'll be answering your questions during the talk. But thank you very much. If you have any questions, you can also email us directly. If you have any questions or you have any inquiries as to what Hesperos could potentially do for you, feel free to contact us. Thank you very much.